All right, well, good evening and welcome everyone to our webinar this evening. I'm Sarah Jenkins. I'm the Executive Director of the National Association for Continence, and we're so glad that you're joining us tonight for this discussion around overactive bladder, urge incontinence, and the treatment options available to help. So I just want to start by telling you a little bit about NAFC. We are the oldest and largest nonprofit that's dedicated to helping those challenged by bladder and bowel incontinence. We receive over 2 million visitors per year and are the go-to resource for those who seek information or support for incontinence. Our website is where we share a lot of our information about diagnoses and the treatment of bladder and bowel related issues. Excuse me. And we have a wealth of information there, podcast downloads, blog articles, message boards where you can talk to others. So I encourage you to check us out. NAFC's mission and purpose is to help those who struggle with incontinence by providing education, community, and support. We know that incontinence impacts over 100 million Americans, but it's often a silent struggle. People are scared to talk about it. Most of them wait about 6 years before even seeking help from a physician. And a lot of that's due to just feeling embarrassed about the condition. So NAFC really tries to empower those patients by providing trusted education, patient stories, and connection through a community that really understands what you're going through. So we're more than just a resource, we're a voice for change, and we advocate daily for better care, better products, and a world that breaks the stigma around bladder and bowel health conditions. So tonight, excuse me, just a quick overview of what we're going to cover. Our keynote speaker is Dr. Travis Bullock, and he's going to review an overview of incontinence, including overactive bladder, urge urinary incontinence, and different treatment options that are available. We're going to really focus on neuromodulation and how that works, and then talk about why shared decision-making is important when you're talking about treatments with your physician. And then finally, we'll provide some different resources and a live Q&A as long as we have time. So please feel free to add your questions in the Q&A throughout the presentation, and we'll get to those at the end. So as I said, our keynote speaker is Dr. Travis Bullock. He's a board-certified fellowship-trained urologist specializing in female pelvic medicine and reconstructive surgery. Dr. Bullock is one of the few urologists in the St. Louis region with the advanced subspecialty training, and his clinical expertise spans female urinary incontinence, pelvic organ prolapse, overactive bladder, neuromodulation, urodynamics, and general urology. He also serves as a principal investigator on multiple ongoing clinical trials, playing an active role in advancing new therapies and improving care for patients with pelvic health concerns. We are incredibly grateful to have him with us tonight to walk through the basics of OAB, review the treatment pathways available, and take a deeper look at neuromodulation, including what it is, how it works, and who it may help. So please join me in welcoming Dr. Travis Bullock.
Hey, good evening, everybody. Thanks for joining us. I know it's a busy time of year, and so I appreciate everyone taking time out of their schedule for this. I'm going to do a very high level going over what urinary incontinence is, all the types of urinary incontinence. We will leave some time for questions at the end. I hope it's informative. I hope everyone enjoys it, and please don't be shy to get us those questions for the end. And I'm going to So let's talk about first is the types of urinary incontinence. I think a lot of people don't realize, they just know that they leak. They don't know that there's actually separate types of urinary incontinence. The first thing to know is what actually is urinary incontinence and what the definition of urinary incontinence is. It's the involuntary loss of urine. So it's whenever you have a leak and you don't want to have that leak, that is called urinary incontinence, a very generic term. A lot of people think it's something only women have, and it's something only women that have babies have. That is actually not the case. Urinary incontinence is common in men, it's common in women. Actually, in the seventh and eighth decade of life, urinary incontinence is actually of equal prevalence in both women and men. But in the younger years, truthfully, we do have more women who suffer from it, and that's due to things like childbirth and the changes that go along with menopause and the pelvic floor changes that go along with aging, having children, and menopause. There's actually multiple different types of urinary incontinence. We call them stress, we call them overactive bladder or urge incontinence. Some people have mixed incontinence, and then very rarely there's something called overflow incontinence. Now, to break all those down, so stress incontinence is probably the one that we hear about the most, or we sort of when we hear the word incontinence, it's probably the one we think about first. And what stress incontinence is, it's that coughing, sneezing, laughing, jumping, that horrible trampoline park kind of leakage. So it's that small drops of urine with some sort of physical activity. And that's typically caused by a weakening of the pelvic floor muscles or a weakening of that sphincter muscle that holds the bladder closed. And things that cause that are things like pregnancy, childbirth, chronic cough, smoking. But that's the one that people actually, when you hear the word urinary incontinence, that's probably the one that most people picture in their head. What's very interesting about that is that's actually not the most common form of incontinence. The most common form of incontinence is actually what we call overactive bladder or urge incontinence. And what overactive bladder and urge incontinence is, it's the I gotta go right now type leakage. So it's the urgency, it's the frequency, it's the getting up at night multiple times to go to the bathroom. It's that loss of urine when you have no warning and you're trying to get to the bathroom, trying to get your pants down real quick, and then all of a sudden you just lose it. It's usually high volume, so it's a lot of leakage rather than just a few drops like stress incontinence is. And it tends to be the one that has the biggest impact on people's quality of life or their happiness or their ability to go out and do things. So it's typically the one that will impact people the most. I sort of I sort of misspoke when I said that overactive bladder and urge incontinence is the most common because actually the most common is mixed. And what mixed is I have components of both stress and urge. So I have the coughing, sneezing, and the exercise. I also have the urgency and the urge leakage and the frequency. We call that mixed. So I have two. But most people with mixed incontinence will generally have one of them that is the most bothersome one or the most prominent one. And a lot of times that actually is the urge. The urge one tends to have the most impact of quality of life because you don't always know when it's going to happen. In general, you know when you're going to jump. I mean, you have a little bit of warning when you cough and can kind of cross your legs. But the urge really can come on with no warning. It can come on very quick. The one that's the most rare is probably the overflow incontinence. So what the overflow incontinence is, it's incontinence that people have when they don't empty their bladders all the way. So imagine sort of trying to run with a full glass of water. You're going to spill little bits of water over the side of that glass, and that's overflow incontinence. Overflow incontinence is pretty uncommon in women. It's far more common in men, and it's usually that incontinence, often with urgency and leakage, that's associated with big prostates and men that don't empty their bladders all the way. We can move on to the next one. I think I've lost control. Oh, there it is. Okay, so why does urinary incontinence happen? Well, it generally happens because of some sort of weakening of the pelvic floor muscles or your body's inability to properly hold and then release that urine at a socially appropriate time when you want to be releasing it. And we used to, for a long time, think it was actually a bladder problem or it was a problem with the bladder itself, but we now sort of believe that's not the case. The overactive bladder or the urge incontinence is actually a nerve problem. So it's a problem with something in the communication between the bladder and the brain that's just not acting right. So it's sometimes if you have like a computer at home with a printer and then you go try to print something from your computer and it doesn't tend to make it to the printer and doesn't print out, you don't actually start taking your printer apart or taking your computer apart. You know it's something wrong with your internet. There's something wrong with the wiring. There's something wrong with the nerves. And that's what we think overactive bladder is. It's a problem with how the nerves and the muscles of the bladder and the pelvic floor sort of talk to the brain. Or the bladder is telling the brain, I'm full, I'm full, I'm full, even though I'm not full. So that is one of the causes. Other causes are with overflow incontinence, it's enlarged prostates or prostate issues in men. Also, enlarged prostates can cause urinary urgency. There's receptors in the bladder that sense urgency. And in men with enlarged prostates, those receptors actually become more prominent and those men have more urgency. Other factors are things like obesity, chronic cough from smoking. Certain medications can cause incontinence. One of them is diuretics. So, like blood pressure medicines that some people take that actually make your body make more urine can cause incontinence. Some of those blood pressure medicines are not only taken for blood pressure, but maybe swelling of the legs. There's also a pressure medicine called ACE inhibitors. And one of their side effects is a cough. And then that cough can lead to stress incontinence. Another important cause of urinary incontinence is actually bowel problems. So, bowel incontinence or constipation or diarrhea and bladder problems tend to go together. And that's because the bowel and the bladder kind of share the same nerves as they come out of the spinal cord. So, if one condition is not going well, it often impacts on the other condition also. Probably one of the most important things I can tell everyone tonight is that urinary incontinence is common. It's extremely common. It's 1 in 3 people. That is more common than diabetes. That's more common than arthritis. That's more common than Alzheimer's disease. More common than all these health problems we talk about all the time. Urinary incontinence is far more common than any of those. But just because it's common doesn't mean that it's normal. So it is a common condition, but it is not a normal condition. And this is something that can be treated, that's treatment options are successful, and there's plenty of physicians out there that care about this problem and want to treat this problem. So the first one we're going to talk about is the most common one, and this is the overactive bladder. So what overactive bladder is, this is that when you hear or feel that all of a sudden I have to go and I have very little warning, I have to get there quick, and if I don't get there quick enough, there's going to be a problem. And it's usually a high volume leakage. This is the most common form of urinary incontinence. It's actually estimated that over 40 million people have overactive bladder or urge incontinence. So it is extremely common. And again, it's really highlighted by urgency, the strong need to urinate with the really inability to delay that urination. Not always, but often accompanied by frequency. We consider frequency to be normal if it's 7 or less times per day. So the average person voids or uses the restroom between 5 and 7 times a day. Anything 8 or more, we sort of consider that abnormal. Overactive bladder typically also is associated with nocturia. Nocturia is a fancy medical word for I get up a lot at night. This tends to be, other than the incontinence, the getting up at night tends to be the thing that bothers the patients the most. It is also one of the most difficult things to fix because there's lots of things that go into getting up at night. It could be swelling of the legs, and then at nighttime you lay down and that fluid comes out of the legs. It could be medications you're taking at bedtime, either maybe diuretics or sleep medications. It could be, volume of fluid intake in the evenings. It could be sleep apnea. Sleep apnea actually makes people go to the bathroom often at night. It actually makes them make more urine. The other frustrating thing about nocturia is expectations, is we actually unfortunately consider getting up twice a night to be normal. So getting up once or twice a night is a normal condition for most people. And then the last sort of symptom of the overactive bladder is actually the urge leakage, or that inability to delay that urge and actually have an accident or having a wetting episode before you can make it to the bathroom in time. The causes for overactive bladder we sort of talked about earlier. It's probably more to do with the nerves that are talking to the bladder, or these nerve signals are misfiring, or the bladder is mistakenly telling the brain it's time to go, it's time to go, it's time to go, even though it's not time to go. While these overactive bladder is present in sort of all age groups from, teenagers and earlier on throughout the entire adult life, it does become more and more common as people get older. And that could be due to hormonal changes, the aging process in general, some sort of bladder irritation, or just sort of the natural, degradation or the nerves just not working well as they have in the past. Overactive bladder really impacts quality of life in a huge way. I can sort of look out in my waiting room and I can tell who's got overactive bladder by the black pants. People who have overactive bladder and then fear wedding accidents really have to limit some of the clothing they can wear. They have to wear black pants or often wear black pants to hide the leaks. They often wear bulky pants to hide the pads or the depends they wear. They skip high school graduations and college graduations because they're have to go to a place where there's assigned seating and they may not, know where the bathroom is or the bathroom may be far away. They're afraid to go places where they don't know where the bathroom is. We call that bathroom mapping. People with urinary incontinence know where the bathroom is everywhere they go so they can get there frequently. While not on the slide, there's also urinary incontinence, and overactive bladder is probably one of the top five reasons for admission to a nursing home, whether that be that family members have difficulty caring for the person or a fall and a fracture due to trying to make it to the bathroom at night and slipping and falling. And then there's huge mental health part of this. Most people, or a high percentage of people with urinary incontinence, suffer from depression and they suffer from isolation and the fear of getting out and the fear of going places with people because of these wedding accidents. So that's really the main reason we are so interested in treating this for people is the impact it has on quality of life. We sort of talked about this also. Urge incontinence is sort of the other part of overactive bladder. Overactive bladder actually comes in two categories. It's the overactive bladder dry, which means these people have urgency and frequency, but don't have accidents. And then there's the overactive bladder wet, which is more common. These people have the urgency, the frequency, but also have the accidents where they can't make it in time. And I'm always also always surprised by, I tell people there's a brain bladder connection, and sort of one way I sort of illustrate it to people so they believe it is I'll bring up your triggers. So a lot of people with urgent incontinence have triggers, something that sets it off. They hear running water, they see a toilet, jingling keys, a garage door opener. Every time I pull in the driveway, it immediately hits me there. Cold temperatures is a big one. And then another huge one is stress and anxiety, definitely can trigger people's overactive bladder as well. So, people who have overactive bladder, these are the things they think of or have to do. They have that gotta go right now feeling. I don't have enough warning. I can't make it there in time. They plan their activities around the bathroom. We call that bathroom mapping. People know that the bathrooms in Target are right in the front at customer service. At the grocery store, they're in the dairy aisle where the milk is. At Home Depot, they're in the plumbing aisle, which I always thought was interesting, but that's where they are at Home Depot and Lowe's. People with overactive bladder get up multiple times at night. They really monitor how much they eat or how much they drink and how much fluid they take in. You'll hear people with urgency and urge incontinence when they have something to do that's outside the house. They'll start managing their fluid intake hours to days beforehand to almost dehydrate themselves so they don't have to go to the bathroom often and don't have these accidents. And they really have to alter their daily life just because of this fear of leakage. Just imagine how just horrible it is to wet your pants in a public place. And that's usually the greatest fear. And that is probably the number one thing that drives people into the office is they had a wetting accident at a public place. Huge interference with daily life, with travel, going on family vacations, social activities, sleep, and then it's a huge toll on self-confidence. So if any of these things sound familiar, it's your body trying to tell you something. And fortunately, this is a process that can be treated. So, what are some of the risk factors or causes for urinary incontinence? Well, we know aging, it does increase with aging. And this is probably because of pelvic floor weakening and maybe, use of the nerves and the bladder muscles over a period of time leads to those nerves not working as well as they have in the past, much like my eyesight and some people's hearing. It's just as we get older, some of these body parts kind of fail us and they just don't work as well as they have in the past. Definitely a risk factor is gender. It is more common in women up until the 70s, and then it's equally as common in women and men. Childbirth is a risk factor. The changes of menopause and the changes of estrogen in the pelvis and the vaginal area is a risk factor. The act of being pregnant, some women will say, well, I had a C-section. Why do I have this problem? Well, sometimes it's the act of being pregnant causes pressure on the pelvic floor and can lead to weakening of those nerves and muscles of the pelvic floor. Menopause is a big risk factor. There's hormones, there's estrogen receptors in the urethra and the vaginal area, which are responsive to estrogen. And many people do find some improvement in symptoms with hormone replacement and vaginal estrogen use for urinary conditions. In men, an enlarged prostate can interfere with bladder emptying and lead to overflow incontinence. There's several neurologic conditions that are associated with urinary incontinence, especially the urge variety, things like stroke, Parkinson's. Some people with Parkinson's have like a tremor of their hand. You can think of overactive bladder as a tremor within the bladder. Multiple sclerosis is definitely a big risk factor, and I have a very high multiple sclerosis population. Upwards of 75–80% of people with multiple sclerosis do have bladder-related symptoms from their multiple sclerosis. And then spinal cord injury. There are medications which can impact urinary functions. Of course, diuretics make your body make more urine. If you take sleeping pills at night or other sedatives, they may sedate you in a way where you don't wake up to go to the bathroom and have nighttime urinary accidents. Muscle relaxants, and then some blood pressure medicines which cause coughing can lead to stress incontinence. There's certain things in your lifestyle, smoking, caffeine intake, alcohol use. Alcohol and caffeine are diuretics. They make your body make more urine. Certain people also say things like acidic foods irritate their bladders. And then obesity and other healthcare conditions or anything that can put extra pressure on the bladder or pelvic muscles can lead to both stress incontinence and urge incontinence. So, big overview of the different types. So, what do we do about it? Well, here's the meat. Let's talk about the treatment options for urge incontinence and overactive bladder. So we traditionally sort of broke the treatment options down into like first line, second line, third line. We start with this, we move on to this, and then we go to this. That's what we did traditionally. A lot of that has changed over the last year based on some new guidelines and some new studies. but a lot of the nomenclature still kind of breaks down to these first line, second line, third line. So the first line are typically, I don't really call them first line. I call them the non-invasive options. I've gotten away from that first line, second line, third line, and I use more of the non-invasive or the non-quote medical options, which are things like bladder training. When you get an urge, try to delay that urge as much as possible to try to retrain your bladder to not just succumb to that urge as soon as you feel it, to try to delay it as long as possible, and then use the bathroom in the absence of urgency. Pelvic floor exercises. We all heard of our Kegel exercises or our Kegel exercises they teach women when they have babies. There are physical therapists out there that specifically do bladder training with women. For the most part, these are all women. It's a one-on-one type physical therapy. It's generally covered by insurance because it's just called a pelvic floor weakness. And these are physical therapists that help men and women with pelvic floor, urinary conditions, pelvic pain, post-pregnancy issues, but they are specially trained people. They don't do typically hips, knees, and backs. They do pelvic floor physical therapy. Fluid management and a dietary modification like limiting your alcohol, limiting your caffeine, limiting your fluids at night if you're a person that gets up at night. Weight loss helps. It puts less pressure on the bladder. Stopping smoking will make the bladder healthier and also would a lot of times will fix a chronic cough, which can lead to incontinence. And then there's some over-the-counter and support devices, like maybe a vaginal pessary that's typically used for prolapse, can help stress incontinence in some ways. And then there's a thing on the market called Impressa, which is sort of it's like a large tampon with a different shape that sort of compresses the urethra against the pelvic bone to inhibit leakage. And a lot of these sort of less invasive or non-medical treatment options we use several of them. We don't just usually use one. We may do a combination of things like bladder retraining, physical therapy, and limit your caffeine, or stop smoking, uh, go to physical therapy, or use a device or some sort of over-the-counter method to help the urinary leakage. Then we typically move on to the second line treatment options. A lot of times these second line treatment options are done in conjunction with the first line treatment options. And I don't typically call them second line treatment. I call them medical therapies. So medications for this problem. There is a variety of medications for this problem. There's actually probably 8 on the market. These different medications, they kind of break down into 2 main groups. One is called anticholinergics, and one is called beta 3 agonists. The anticholinergics go by names like, and some people on this have maybe been on these before, ditropan, oxybutynin, Detrol, Vesicare, Sanctura, Enabilex, Darphenocin, Oxytrol, Gelneek. I can go on and on and on. These are basically all the same medicines or types of medicines, just made by different companies. So it's sort of like Coke and Pepsi, you know, or Angel Soft and Charmin, they're both kind of toilet paper, just made by different companies. Some of these anticholinergic medications like ditropan or Detrol or Vesicare can have some side effects, typically dry mouth, constipation, blurry vision, and then there has been some press with these anticholinergics and some interference with memory or problems remembering or memory dysfunction. The other class of medications are something called beta 3 agonists. They kind of work in a different way. There is one generic beta 3 agonist now, but the beta 3 agonists, while they have less side effects, they tend to be more expensive. Their side effects are stuffy nose and then really rarely high blood pressure. And these medications, there's 2 of them. There's one called Myrbetriq or Mirabegron. That one does come in generic. Surprisingly, the generic is not usually any cheaper than the name brand. And there's another one called Gemtesa or Virbegron. Those are the 2 beta 3 agonists. A lot of people ask me which one of these medicines works the best. There's not really one that works the quote the best. If there was one that worked the best, well, that would be that would it would rise to the top and it'd be the only medication out there because it worked the best. We would, of course, want to give everyone the medication that works the best. Now, I will say there are some subtle differences, and one may work better than another for one person than it does for another. But generally, when we change around these medicines, we're not always going for which one works the best. It's actually we're sometimes going for the one that's has the fewer side effects or the one that's covered best by the health insurance. Is generally what we're going after when we pick or change these medications. And then we have, so typically we used to do this first line, second line, third line. Now we do this thing called shared decision making because there's also these things that were traditionally called third line options, things like neuromodulation or Botox that we sort of saved after the first and second line didn't work or weren't beneficial or had side effects or were not covered by insurance and couldn't be afforded. Then we moved on to some of these more procedural aspects of treatment of overactive bladder. But now it's sort of a wheel. We kind of will talk about all these things often at the same time. We'll talk about lifestyle changes in everybody. And yes, I recommend Kegel exercises and fluid limitation and bladder retraining in everyone. We'll talk about medications with most people, and oftentimes we'll start medications even at that first visit because a lot of times people come in, they are so ready to do something that you're not typically looking for just do your Kegel exercises. We'll typically start medicine a lot the first time. But we'll also talk about these more advanced options, like injecting Botox into the bladder, like something called sacral neuromodulation, or tibial neuromodulation, or tibial nerve stimulation. Now, I would sometimes love to kind of start off with these more advanced options earlier on, but a lot of that is also driven by insurance companies. A lot of times, insurance companies won't let me move on or allow us to move on to a more advanced option until we've tried some medications or lifestyle interventions first. Then I don't always think that's inappropriate. So let's talk about some of these third line options, and I sort of like to call them advanced options. Oftentimes we move into these if medications and behavioral therapies don't work or are not beneficial or have significant side effects. And one of these advanced therapies is something called neuromodulation. So I think I spent a lot of time talking in the beginning how this urge incontinence and overactive bladder is really a brain and bladder miscommunication issue. So for some reason, those nerves in the bladder are not talking to the brain appropriately. And that's when neuromodulation comes in. So we're trying to change those nerves to restore that communication between the brain and the bladder. And we use that with low levels of electrical stimulation to talk to those nerves to try to fix those reflexes. We often will move into this when lifestyle changes or medications are not enough, but in many instances, we hopefully can stop your medications, but those lifestyle changes are typically a long-term thing. You can't drink 48 ounces of Mountain Dew every day and not expect to have bladder problems. So we still do need to be cognizant of some lifestyle changes with all these treatment options. Great thing about neuromodulation is a person can control it, they can adjust it. It doesn't damage these nerves, and they can really use it to personalize their therapy. And there's actually three types of neuromodulation, or three ways that we can adjust or stimulate these nerves to improve urinary problems. And one is something called sacral nerve stimulation, one is called percutaneous nerve stimulation, and one is called tibial nerve stimulation. So sacral nerves are little nerves that come out of your sacrum, which is the lower part of your backbone, right about where you sit. That kind of flat, broad bone right above your for lack of a better term, butt crack, or more medical term, gluteal cleft. That's where the sacrum is. And there's nerves that come out of that part of your back and actually wrap around, go to your bladder and bowels, and they go all the way to the tips of your feet. So that's where we start talking about tibial nerve. The tibial nerve is actually in your ankle. So believe it or not, there is a nerve in your ankle that is a branch of the nerves that come from your bladder and bowels, and we can actually use that nerve in your ankle to calm your bladder. And that's where tibial nerve stimulation or tibial neuromodulation comes in. So, when we talk about sacral nerve stimulation or sacral nerve therapy, we're talking about usually there's this device out there called InterStim. So, this device has been around for 27, 28 years. Almost 500,000 people have one of these devices. And basically, what it is it's a small pacemaker that gets implanted underneath the skin and fat of your butt cheek, and then there is a little wire or a lead that talks to the nerves as they come out of the sacrum and go to the bladder. So that little battery provides this little bit of electrical signals to those sacral nerves to sort of calm the bladder down and sort of rearrange those voiding reflexes to help the urge. A lot of people think that there's sort of button you have to push to go to the bathroom, or do I have to interact with it in some way when it's time to urinate? And that's not the case. It's on all the time. It sends these signals to just calm the bladder and sort of rewrite the voiding reflexes. It is a battery, just like a pacemaker. It's actually made by the same company that makes pacemaker batteries. Battery is good for 10 years or longer. Um, Minimal follow-ups. I see most people that have these about once a year in the office. They are MRI compatible. They're safe to go to the airport. And it's really is a great option for patients with significant urgency and urge incontinence that really haven't responded to medicines or more conservative treatments. There are rare side effects. It is a surgical procedure to put in. So there's small risks of things like bleeding or infection, or we call it abnormal stimulation, or feeling that those little electrical signals in a painful way that can be adjusted. We don't just typically take people and put a pacemaker in their body. We typically do a trial first. So people wear an external one for a week first. We actually, under local, when we trial this, we put a temporary one in, and then people wear an external battery on a belt for a week to see if they're a candidate. So they get to try it out before they buy it. So it's sort of like if you went to a shoe store and you saw, a rack of shoes, and you kind of saw a pair of shoes you thought you liked. You weren't sure if it went with your outfits. You weren't sure if they were comfortable. So you get to try this. You could try them out for a week and then choose to buy them. That's how this sort of works. We do a temporary sort of a procedure, or under local, we can just put a temporary lead in. You can wear an externalized battery for a week to try it out first before you decide if you're a candidate for something like this first. Um, Getting away from sacral neuromodulation, there's something called percutaneous tibial neuromodulation. This has been around for probably nearly 20 years now. There's again that little nerve in your ankle, which is a branch of the nerves to your bladder. Coincidentally, the inner part of the ankle is actually the ancient Chinese acupuncture point for the bladder. So even ancient Chinese knew that there was something about this nerve in the ankle which helped bladder function. And there's a device out there called Nuro. It's an office-based device where patients come into the office and we take it's an acupuncture needle, believe it or not, and we place it in the ankle and actually nearby that nerve that goes to your bladder. And then we hook it up to an external battery for about 30 minutes. And then while that external battery is on, it takes signals up your leg, all the way to your bladder, all the way to your brain to calm those bladder reflexes. While the upside is it's really minimally invasive, it's just something that's done at the office. At the end of the office appointment, we just kind of take the acupuncture needle out. The sort of downsides is there are a lot of sessions. People typically need to come once a week for 12 weeks to sort of get this started. And then there's a maintenance program that has to be done once every few weeks or once a month, typically indefinitely. So there are a lot of office visits that go along with this, which are sort of that is its big drawback. But on the flip side, it's super minimally invasive. It's non-surgical, it's safe, it's effective, it does reduce urgency and frequency. And the only real side effects can be some mild temporary discomfort at the stimulation site or at the needle site. Sort of the newest thing of these all are something called implantable tibial nerve stimulation. So remember how I said on the last slide that getting that percutaneous tibial nerve stimulation, people had to have to come into the office every week to get that little needle placed, hooked into the battery, wait for 30 minutes, go home, come back the next week. So most recently, there is an FDA approved device called AltaViva, which is that tibial nerve stimulation, but as an implantable battery. So it's a small battery about the size of two postage stamps that can actually be implanted surgically in the ankle next to that tibial nerve. It's actually done under local, so it's done under numbing medicine. It's outpatient. When it's done, when we perform this, people can actually drive themselves in and home. It is a small battery that people do not have to interact with. They don't have to do anything to it on a daily basis. All they really need to do is recharge it every 6 to 12 months because the battery does wear out and has to be recharged. There's an external device that looks like an ankle bracelet that you put on your ankle to recharge it every 6 to 12 months. And that battery can last up to 15 years. And it's meant for urgency and urge leakage. And it's sort of akin to that sacral nerve stimulation, but affecting the nerves further down in the leg in a less invasive way. So to try to wrap this up, talking about treatment journey, so trying to choose the right treatment for you is extremely important. Not every treatment is right for every patient. Some people get great benefit from fluid limitation and pelvic floor physical therapy, and that will fix their problem. And they're compliant with physical therapy and they do their exercises daily, and it's a great treatment options for them. Some people do well with medications and have very minimal side effects, and the medicines work well for them. And that is a great treatment option. There are also these sort of more procedural therapies like tibial neuromodulation, sacral neuromodulation, percutaneous tibial nerve stimulation. There are doctors out there that will offer you all these therapies. They'll offer you everything from physical therapy all the way up to sacral neuromodulation, everything in between. It's a very in-depth conversation. It's a very important conversation, and most people can find the right treatment for them if they seek out a specialist in their area who really is invested in treating these problems. Um, Sort of the biggest hurdle to treating these problems is making that first appointment. I mean, this is an embarrassing problem. It's a lot of people think because it's a quality of life issue, it's not important. I'm here to tell you it is. I know it's embarrassing. It's hard to kind of raise your hand and say, I have this problem. I'm going to go talk to someone about it. There's a lot of shame that goes along with it. You think many people think they're the only ones that have this problem, and I'm going to go talk to the doctor. They're going to be shocked about how bad my incontinence is. That is not the case. There are people out there that want to treat this. If you bring this up to a physician, your primary care doctor, your gynecologist, your urologist, and they don't give you the answer that you want, don't take that as the answer. Keep seeking that answer. There are people out there that definitely want to help you with this problem. Don't be afraid to ask about all treatment options. Be an advocate for yourself. And then, be aware that, there's a little bit of trial and error. Sometimes the first thing we try doesn't work. We actually, one of the big problems we have with this urge incontinence and incontinence in general is a lot of times we'll see people once in the office and we try a therapy, it doesn't work right away, or they have side effects, and then they're sort of lost forever. So it's pretty common for us to not always fix this problem on the first visit. It may take follow-up visits. It may take trying a few different treatment options to try to figure out which one is right for you. But I encourage you to stick with it, be your advocate, and don't be afraid to keep looking for those answers until you get them. NAFC has tons of resources out there online. They're on their website. They have many podcasts on all your podcast players. There's bladder diaries online. There's brochures and patient education materials that explain overactive bladder. There's a find a physician on the website where you can find a doctor in your area by typing in your zip code or someone who really specializes in this area. There's a variety of message boards and blogs. So NAFC is a great resource for patients with urinary incontinence or caregivers of family members with urinary incontinence as well. Medtronic, who makes these neuromodulation devices, also has information online. The talkleaks.com bladder, you can go get overactive bladder resources there. There's videos, there's patient testimonials. They have specific websites for sacral neuromodulation or InterStim, and then specific websites for tibial neuromodulation called AltaViva. These are very high quality websites, tons of really impactful information that you can go through and come armed with questions when you meet with a doctor for the first time. So, key takeaways. Overactive bladder and urge incontinence are common. They are common. They are not normal. They are treatable. Not all treatments are surgery. None of the treatments are invasive. Often we can find a treatment for you that's going to be highly effective as well with low side effects. There are a variety of options available, and there's plenty of doctors, and I'm sure there's one in everyone's area who really is dedicated to treating this problem. Treatment options are lifestyle changes, Kegel exercises, medications, neuromodulation, and everything and anything in between. NAFC and Medtronic do offer a variety of online resources and websites that can provide patient education so you can really advocate for yourself and come armed at those doctor appointments. And now we're going to open up the floor to questions. Thanks for joining us today.
Thank you so much, Dr. Bullock. That was great information, so helpful. So yeah, if you have questions, please submit them in the chat and we will answer as many as we can in the next 10 minutes or so. And Holly Capetis from our marketing team is going to lead the Q&A session.
Great. Yes. Thank you, Dr. Bullock. We got some feedback in the chat that you've done a wonderful job. It was very informative. So thank you.
Well, thank you for having me.
All right, let's go through the few we have. And if you are looking to enter a question, if you put your cursor down towards the bottom of the slides and hover over, there is a Q&A icon, and you just click on that and you should be able to ask a question. I think there's also an option to ask it anonymously as well. And as Sarah said, we'll try to get to as many as we can with the time we have left. And feel free to drop in your questions. Whichever ones we don't get to, we'll try to answer in a follow-up podcast. Okay, so one of the questions was asking about post-prostatectomies and if any of these options could be used to treat, I'm assuming, urinary incontinence from that.
So after prostatectomy, people can develop both types of urinary incontinence. The first question that you should need to ask your physician and what you have to find out is what type of incontinence it is. So if it is the urge incontinence, which is the gotta go right now incontinence, which can happen with prostate cancer surgery, then yes, all these treatment options behavioral therapies, medications, Kegel exercises, neuromodulation, medications, all that are available to you. Now, some men after prostate surgery can have stress incontinence, which is the other type of leakage, that leakage of activities, that cough, that sneeze, that cutting the grass, lifting something heavy. That type of leakage or stress incontinence will not be addressed by any of these therapies. There are a variety of other therapies for post-prostatectomy stress incontinence that are not usually medication based, but pelvic floor physical therapy and Kegel exercises and fluid limitation and bladder training can help with stress incontinence as well, but generally not medications nor neuromodulation.
Great, thank you. We had somebody that asked about having hardware from two fusions and, how much hardware can a body take? So is that a
Yeah.
consideration? Are these bladder devices an option for someone like that?
So I've been asked that a lot. People say I've had a lot of back surgery. I have rods and screws and poles and a whole variety of things in my back. Where we are working for bladder control is at the level of the sacral nerve 3. So that is way down there. That is far below anywhere where people are having back fusions or cages placed or screws and bolts placed. So previous back surgery is typically not an option, not a difficult problem or not something that's going to impact on these devices at all.
Great. Question on how do you find a pelvic floor therapist?
So there actually is a website out there. So the American Board of Physical Therapy, APTA, has a website out there where you can find a physical therapist in your area. Let me look at I have a website booked called Find a Pelvic Floor Physical Therapist. It's pelvicrehab.com is another place to find a pelvic floor physical therapist. And you can actually just type in your own zip code and it will tell you the physical therapist in your area.
Great. Um, what about if third line treatments don't work? What is next?
So the third line treatments for urge incontinence and overactive bladder, we didn't actually discuss all of them. We discussed neuromodulation. So there is another third line therapy out there. It's Botox. We've all heard of Botox for our face, or sweating or any other variety of things, migraines that people get Botox for. We actually also FDA approved for many years now. We can actually use Botox in people's bladders with urge incontinence. This is done in the office. We look inside the bladder with a little tiny telescope called a cystoscope and can give injections of Botox within the bladder. It is FDA approved. It is covered by insurance. It is another treatment option for urge incontinence. It does have some downsides. It's upside, very minimally invasive, done in the office. Downside, it's not permanent. Has to be done every 6 months. And the other downside is its main side effect is, well, a little bit of blood in the urine for a day, a little bit of burning when you pee, a small risk of infection. But the side effect that gets the most that's publicized the most is the small chance of inability to empty the bladder. Sometimes the Botox can quiet the bladder so much people can't empty. And then they have to catheterize themselves or pass a little straw into the bladder through either the penis or in the urethra at the vagina a few times a day to empty the bladder. This happens rarely. It's about 3 to 5% of people. It's not permanent. It wears off in general at about 6 or 8 weeks. So that is another option. If all these options fail, there are some things that are done very rarely now, fortunately, like a bladder augment, where we can take a piece of your, it's a big surgery through the belly, where we take a piece of your intestines and sew it onto your bladder to make your bladder a really big bag that holds lots of urine. Or some people, in extremely rare cases, actually, the incontinence has gotten so bad and it's such an impact on quality of life that their bladder's removed. But fortunately, that is rarely, we don't really advocate this often, but permanent catheters or suprapubic tubes, those are also sort of things we use rarely for really refractory incontinence.
Thank you. Um, let's see here. Here's a good question. Should I start with a urologist?
Well, we urologists, I think many doctors can have a real interest in this area. Like I know a primary care doctor who's extremely interested in this area. I know pediatricians who are really interested in this with children, gynecologists that can be interested in this. I know a GI doctor who has an interest in this area. So there are always doctors out there of many specialties that are interested in this area. But probably if you're really looking for the bang for your buck, the person who's going to have the most interest in this is either your urologist and specifically probably your urologist who is, has a specially trained in female pelvic medicine or urogynecology. But there are urologists in there that treat men for this condition also. Your primary care still is a good place to start. They can always prescribe medicines. They can always send you to physical therapy. Same with a gynecologist. But yes, urologists do have a particular slant to this, and we would probably be the ones who would offer most of the advanced therapies. Occasionally, a general gynecologist would, or a urogynecologist would as well.
Great. I think maybe the last one that we'll end on, as we may end here, may cut us off, is are these devices covered by insurance?
Yes, so these devices have been around for a long time. The sacral neuromodulation or InterStims got FDA approved 28 years ago. So it is a well-established treatment option for this condition. And they are approved by insurance if certain criteria are met. And those criteria are usually you have failed behavioral techniques and Kegel exercises, and you've either tried and failed or had side effects or are not candidates for medications. Typically, then you would be covered for a sacral nerve stimulation device. Now, in terms of the tibial neuromodulation, those are fairly new, and we are still working through insurance coverage on some of those. They're covered already by Medicare, but for like specific United Healthcare, Aetna, Blue Cross Blue Shield, I have to call and discuss it with the insurance carrier first. But as a general rule, they are.
Awesome. Well, thank you so much. As I mentioned, other questions, we've taken note here and we'll answer those in a follow-up podcast with you, Dr. Bullock. Thank
That's
you.
great.
Thank you, guys. Well, thank you everybody who attended, and we will be sending out a recording of this webinar and a follow-up email within a couple of days. It'll be on our YouTube channel as well, and on our website. So keep an eye out for us, and please visit nafc.org to learn more. Thanks.
Thanks, everyone.